Good evening, dear colleagues and friends of endoscopy. It's my great pleasure to welcome so many participants all over Europe to tonight's FUJIFILM Satellite webinar, hosted by the ESGE. The topic is From Screening to Treatment, the new champions of endoscopy, G-Eye and CadEye. First, I would like to welcome our experts, Paggi from the Valduce Hospital in Italy, Roger Wanner from a gastroenterology practice in Switzerland, and Alessandro Repici from the Humanitas Hospital in Italy. My name is Patrick Aepli, Head of Gastroenterology and Hepatology at the Cantonal Hospital in Lucerne, Switzerland. As you probably already realized, it will be a Swiss-Italian production tonight, but don't be afraid. We will talk about much hotter topics than cheese and pasta. It's well known that one of the most important quality indicators for screening colonoscopy is the adenoma detection rate, the so-called ADR, because of the extensive evidence that it correlates directly with colorectal cancer. Several studies showed that polypectomy prevents cancer and reduces colorectal cancer mortality up to 50%. However, we also know from the literature that colonoscopy is perhaps not that protective as we originally thought, particularly for right-sided lesions. We also must be aware that not all colonoscopists are equal. There is a significant 3 to 6-fold variation in the detection rate and the miss rate between different endoscopists. That's why we are grateful if new and promising technologies will support us to find most of the at least relevant lesions. In the next hour, we will show you the advantages from 2 of the latest technologies from FUJIFILM in the field of colonoscopy, called CadEye and G-Eye. The latter guarantees an improved view by opening folds, and the AI system CadEye helps us to detect, delineate, and characterize colonic lesions. I'm quite confident that you will be thrilled after our webinar. As you probably know, since several years, ESGE offers you the opportunity to view high-quality presentations on hot endoscopy topics from world leaders in the field. And you are invited to interact with speakers and participate by submitting questions. So please use this opportunity and put in your questions using the Q&A function. Your interactive participation is highly appreciated. Following the custom ladies first, we will now start with Paggi. She will talk about improvement of ADR from LCI to AI. Please, Silvia, air and screen are yours.
Thank you, Patrick, and thanks to the organizers for inviting me to this webinar. My topic is to speak about improvement of adenoma detection from LCI to AI. As we all know, LCI is one of the light modalities which can be achieved by combining the LEDs bulb lights in the Luxio Fuji series. And LCI is the light mode characterized by the highest brightness. So it allows to achieve a wide field view, which is ideal for adenoma detection. Again, LCI increases color contrast within the red spectrum area, so red zones appear even redder and white zones even wider, which is a very useful feature to detect a lesion and to discriminate it from surrounding mucosa. So LCI was hypothesized as the theoretic light ideal for adenoma detection. And we had in the last 4 to 5 years studies in the literature published with increasing levels of evidence. First of all, we had proof of concept studies, aimed at evaluating whether LCI could increase lesion visibility, either subjectively by endoscopist's judgment or objectively by computerized analysis of color contrast. Well, these studies consistently shown that LCI increases lesion visibility. Then we passed to back-to-back studies aimed at evaluating whether LCI could reduce the miss rate of lesions in the double inspection of the whole or of the right colon. These studies evaluated polyps or adenomas or SSL miss rates. And again, they consistently have demonstrated that LCI is able to reduce lesion miss rate. Moreover, in some of these studies, also additional adenoma detection rate was evaluated, which means that these studies evaluated the proportion of patients with at least one adenoma detected at the second inspection only. These studies showed that LCI is also able to increase additional adenoma detection rate. However, we all know that back-to-back studies have some limitations, and for other endoscopy techniques, the benefits obtained in back-to-back studies were not confirmed by randomized controlled trials. We have 5 RCTs in the literature which evaluated adenoma detection rate either in unselected or screening patients. And they all demonstrated that LCI is able to increase adenoma detection rate. Actually, there's also a Dutch multicenter trial on the surveillance in Lynch syndrome patients, which demonstrated no benefits in terms of adenoma detection rate, but an increase of the mean number of adenomas per patient. As an example, I will show you the results of one of these randomized controlled trials, which was coordinated by our center. We randomized patients participating in the regional and national screening program to receive a complete white light of oral CI colonoscopy in both insertion and withdrawal phase of the procedure. And we demonstrated that there was a 20% relative increase in adenoma detection rate by using LCI, with no difference in terms of advanced adenoma detection rate and of SSL's detection rate. LCI was confirmed as an independent predictor of adenoma detection, also in logistic regression analysis, along with male gender, increasing age, and highest level of bowel preparation. Last but not least, in 2021, there is a systematic review and meta-analysis which included all the randomized controlled trials we mentioned, and also back-to-back studies with the specific aim of additional adenoma detection rate. And this meta-analysis confirmed that LCI increases adenoma detection rate. So it can seem all perfect, but we know that to err is human. And here comes AI to help. The first evidences we have came from artificial settings. In this case, for example, artificial intelligence was applied to videos of back-to-back examinations. And this study shows that artificial intelligence was able to identify about the 80% of polyps missed by endoscopists at first pass and found at second pass evaluation. If we have said that for LCI, we had a progression of evidence of level of evidence through the years, In case of artificial intelligence, we can speak about an explosion of evidence, because along with ex vivo studies like this one, we had randomized controlled trials evaluating adenoma detection rate in patients undergoing colonoscopy with or without artificial intelligence. This study, for example, coordinated by Professor Repici, showed that artificial intelligence increases adenoma detection rate without increasing withdrawal time of the procedures, is able to provide a higher benefit for diminutive and small lesions, and increases the detection of either polypoid or non-polypoid lesions and proximal and distal ones. And again, along with randomized controlled trial, meta-analysis came. In this case, for example, 5 RCTs were included, and the meta-analysis shows that artificial intelligence can increase adenoma detection rate with the highest level of benefits, again, for smaller lesions and independently of the morphology or of the location of the polyps. It is funny because in literature in 2021, we had 8 meta-analyses, including up to 8 randomized controlled trials. As you can see, the results are very consistent across the meta-analysis, and they all show that artificial intelligence is useful to increase adenoma detection rate. However, this meta-analysis had also some limitations. They included mostly expert endoscopists, a low number of patients which were quite heterogeneous for indication to the procedure, and as of interest for this meeting, no data on CadEye, which is artificial intelligence by FUJIFILMs, were not included. The only data we have for CadEye published in the literature are data on the analysis of video segments from colonoscopies performed by experts or non-experts endoscopists. I will not go through these slides, but I will provide you the main message, which is that when CadEye is applied to non-expert colonoscopies, their performances are not statistically different from those of the experts in terms of adenoma detection. But this is a study in an artificial setting. The only data available for CadEye are the preliminary results of a multi-center trial we are coordinating, including patients undergoing colonoscopy for screening purposes. It has primary prevention or after the finding of fecal immunochemical test positivity. Patients are randomized to receive a HD white light colonoscopy with or without CadEye, and has started in January 2021. It is still ongoing, so we don't have definitive results yet. The study has as the main outcome measure the adenoma detection rate, and is based on an hypothesis to increase adenoma detection from 40 to 50%. So that we have to include 770 patients. Up to now, we have included about 470 patients, which, as you can see, are well balanced across the study groups. And as a preliminary result, we can say that artificial intelligence is able to increase adenoma detection rate in the numbers and in the proportion estimated by the calculation of the sample size. But we know that different approaches can be used to increase adenoma detection, not only artificial intelligence and chromoendoscopy, but also the application and the use of devices to increase mucosal visualization. In this network meta-analysis, the authors seem to suggest that artificial intelligence is the approach which mostly influences adenoma detection, but the future could be represented by the combination of different modalities to increase adenoma detection. For example, in this study on video segments, CadEye was applied to colonoscopies performed in LCI mode. And this combination provided 100% sensitivity for adenomas and also for SSLs, with a very, very low false positive rate. So stay tuned, because many news can come in the future. Thank again for the invitation, and thanks to all of you for your attention.
Thank you, Silvia. Great talk. You nicely showed us that LCI, as well as the support from AI, like CadEye, may increase our ADR, making our performance better and therefore optimizes treatment quality for our patients. Would you recommend to use LCI as a standard for the withdrawal in screening colonoscopy?
Yes, and also it is also the conclusion of the meta-analysis I cited. The authors suggest that LCI should represent the routine light mode, at least for withdrawal phase, because it's not it does not increase the fatigue of the endoscopist, because it is a very bright light. So it's not like a blue-based imaging, which needs force the endoscopist to go close to the mucosa and increases the workload of each procedure. It's not, it does not increase the fatigue of the endoscopist, and consistently has been shown to increase adenoma detection rate. So it's not just my opinion that LCI should be used as exploration light during the withdrawal of the procedure.
Okay, thank you. There is a question, a first question from the audience. It's asked if the increase in ADR by CadEye is due to major increase in very small diminutive polyps, which have a very low potential for malignant transformation, as we know. Does CadEye increase the detection also of larger polyps more than 1 centimeter?
It's interesting because other AI technologies have shown that most of the increase is for diminutive and small adenomas. We don't have this data on our study yet because we have only preliminary results. So all of these sub-analyses have not been performed yet. But the increase in the detection of diminutive lesions may be not relevant for the lesion itself, but the endoscopists who detect more diminutive lesions are those who have developed the better mucosal exploration techniques. So the detection of diminutive polyps can be considered as a proxy of an adequate mucosal exploration. Moreover, the number of diminutive adenomas has an impact on surveillance intervals. So maybe a patient could be categorized as having a higher risk of developing also relevant lesions in its future. So it can be addressed to receive a colonoscopy in 3 years instead of 5, maybe because it has 3 or 4 diminutive adenomas. So in my opinion, it's useful also to increase the detection of small and diminutive lesions, because it has an impact on patients' perspective.
Thank you, Silvia. We will see each other later for the discussion. Now we will proceed to the second lecture, which comes from Roger Wanner in Zurich, Switzerland. Roger will tell us about his clinical experience in screening colonoscopy using CadEye and G-Eye. Please, Roger.
Yes, thank you, Patrick, for the introduction. It's a great pleasure for me to be involved in this teaching video. My name is Roger Wanner. I'm a gastroenterologist in a private practice in Zurich, Switzerland. I had experience of using CadEye during the last 18 months and tested the GI in the last couple of months. So during that time, I performed about 500 screening procedures using the CadEye. So I think I have a lot of experience using this artificial intelligence, and I want to try to show you some practical aspects and experiences. I will talk about a bit about the advantages of CadEye and G-Eye, especially in the daily routine of our colonoscopy patients. What is our goal in screening colonoscopies? Our goal is to prevent colon cancer. And when we do screening colonoscopies, there is a fair amount of techniques to improve our quality and to get better results. Our measure of quality is the adenoma detection rate. And CadEye has been shown to maximize the adenoma detection rate. In our experience, we could increase the adenoma detection rate almost by 20%, from 49 to 58%. I'm gonna show you today how to work with CadEye and G-Eye with some examples and pitfalls. CadEye works in real time together with the endoscopist to detect lesions in the colon. It has been developed utilizing AI deep learning technologies. One can switch on and off the algorithm at every time during the procedure. Usually I switch it on during the withdrawal of the endoscope. During the withdrawal, the detection mode, as you see it here on this slide, is possible with the white light and the LCA. Generally, I only use the LCA mode. When CadEye detects a lesion, a detection box displays the area with the suspicious lesion. After that, you can switch to the characterization mode. The characterization mode is switched on by using the BLI mode of the endoscope. This function analyzes in real time again and without freezing or zooming if a polyp is hyperplastic or neoplastic. The diagnosis is visually indicated by the use of different colors codes on the position map you see on the right lower box. Green means hyperplastic polyps, yellow is for neoplastic polyps. In this movie, you can see how CadEye works during a routine colonoscopy. First, the withdrawal in the LCI mode. Now you can see the polyp. And if you, as an experienced endoscopist, agree with the CadEye, you can switch to the characterization mode, and you see it very nicely here. And the characterization mode diagnoses the polyp of a neoplastic polyp. Pathology showed a low-grade dysplastic adenoma in this case. The other new technology that helps us to increase our adenoma detection rate is the G-Eye. The G-Eye is a unique balloon technique. It is constructed on a standard endoscope with a permanently integrated and reusable balloon at the bending section. The balloon can be inflated upon need during the procedure, as you can see here in this movie. Now it slowly inflates. By the way, the inflation is controlled by an external inflation system with a foot pedal. The balloon is pressure controlled and not volume controlled, so you can easily pull it through narrow areas, for example, through the anus. but you are not able to use it as a dilatation balloon. As you all know, one of the big problems we face in screening colonoscopy are missed polyps behind falls. Data show that we miss about 30% of polyps. The balloon endoscope is the balloon endoscope is inserted conventionally through the colon with the balloon deflated, and once the cecum is reached, the balloon can be inflated. When retrieving the endoscope, the balloon straightens the intestinal folds and smoothing colon topography. Another effect is the balloon centralizes the endoscopic optic and enhances so mucosal visibility. Another aspect of the balloon endoscopy, it's during interventional sessions, the balloon helps to stabilize the endoscope and hinders colonic slippage. So the balloon can be inflated into an anchoring position and maintains the endoscope position and enabling intervention. So during colonoscopies, you are quicker, it's easier to remove polyps, and it's easier to retrieve the specimen. Of course, during the endoscopy, you don't see the balloon, but of course you can feel it. The brilliant thing of the balloon, it allows you to straighten any looping. As you can see on this video, you can retrieve and withdraw your endoscope. The maneuverability is not limited. As you can see on the video, you can push and pull the scope, and even rotations are possible. You also see how the folds are flattened, and the visibility of the mucosa is excellent. Sorry. On this slide, you see our endoscopy unit. On the top is a monitor, then the Fuji 7000 light source and processor. Then the next level is the aquajet and CO2 insufflation system. Next is the suction pump. And at the bottom rack, there are the G-Eye controller and the CadEye processor. On the floor, we are almost like a drummer. We have different pedals. Again, from the left to the right, you might recognize them. First is the aquajet, then the Irby pedals, and on the right side, there are the pedals from the G-Eye balloon. I'm going to show you some examples of CadEye and G-Eye assisted colonoscopies. On this first slide, you see one example of a small polyp which is marked by the detection box. When you switch to the characterization mode, the BLI light, you see that the status gets green, and on the position map, the suspicious lesion is highlighted. Here you can see a small polyp on the corner of the image highlighted by the detection box. Characterization then shows us a neoplastic lesion, which turned out to be a low-grade adenoma. One of the big advantages of the CadEye is that it recognizes smallest lesions of some millimeters. Here, the characterization mode was not able to support the endoscopies, but I assume any of us would remove this lesion, and the pathology turned out to be a small adenoma. Here, another example of a small sessile polyp characterized as neoplastic. So far, the artificial intelligence is great support for any endoscopist during screening colonoscopies, and it will not replace the doctor. And in the next example, all of us can see this flat lesion, maybe more than a centimeter. And I already have here the characterization mode, switching to the LCI. And you see CadEye is not able to detect this small lesion, but I think all of us agreed to remove that, and it turned out to be a sessile serrated adenoma. Another example of a false positive, false positive lesion is shown here. So again, a very small lesion of some millimeters, and the CadEye detects it and characterizes it as hyperplastic, and the pathology showed us just lymphatic tissue. So, summary, CadEye works fast in real time, and it helps us to improve our ADR by recognizing small lesions, multiple polyps, and lesions at the corner of the image. The G-Eye improves our ADR through straightening column folds, centralizing the endoscope optics, and eliminating bowel slippage. So you can work quicker, it's easier to remove polyps, and retrieve the specimen easily. What are our wishes for the future? I love to have a better and more precise characterization mode that is able to differ between sessile serrated lesions or hyperplastic polyps. I wish to have a system that is able to differ between low-grade and high-grade dysplastic polyps, which might support the strategy to resect and discard for the future. And of course, we are looking forward to use AI in upper endoscopy, maybe for Barrett surveillance. If you like to get more information about artificial intelligence in gastroenterology, you're invited to visit my homepage. You can see the URL at the top. So thank you for listening. And Patrick, maybe there are some questions.
Yeah, thank you, Roger, for your speech, which contained nice practical examples about CadEye and G-Eye and showed that all of us have a potential to become a drummer. You clearly demonstrated that the use of these systems may make endoscopists' life easier. And yeah, there are some questions from the audience. One participant is interested in knowing if it's more difficult to get into the terminal ileum using a G-Eye.
No. When you introduce the endoscope, you have the balloon deflated, and so it's like a standard endoscope with a normal diameter, and it's no problem to intubate the terminal ileum. And what I already tried is a push enteroscopy for the ileum or jejunum, and there you can inflate the balloon, and you have excellent view for the jejunum. So it's also possible to use the balloon in the small bowel. Yeah.
Okay. Another question is about the lifetime from such a balloon. Is it necessary to change the balloon every 1,000 colonoscopies, or yeah, do you have experience about?
Well, myself, I don't have any experience, but the producer says that they have about 1,000 endoscopies to remove or to replace the balloon. But in our experience with about 200 endoscopies, we never had problems with the balloons. Yeah.
And the reprocessing of this special type of scope is like a normal scope, or do you have to take care for something special?
Mm-hmm. It's slightly different than a normal scope, but you have to inflate the balloon and wash it separately, but you need about 1 or 2 minutes more time for the reprocessing of this endoscope. But the other steps are standard steps. You can use it normally.
Okay, thank you, Roger. We will see each other later
in
the discussion round. So finally, it's my pleasure to announce Alessandro Repici for the last speech about innovation for advanced detection and treatment of colorectal lesions. Alessandro, we are looking forward to your presentation.
Thanks to FUJIFILM and thanks to ESGE for this invitation. I'm so glad so many people following our webinar. And also I like this Swiss Italian that will be pasta and cheese, because at the time it's the right time to have pasta and cheese for everybody. So also congratulations to Sylvia and Roger for the outstanding presentation. Always they are superb, and I think they already said most of the things they are going to repeat. So when we do colonoscopy, we have three main goals. So the first goal is just detection. We need to find as much as possible all polyps into the colon. I don't like that discussion about, okay, you are increasing your adenoma detection rate with non-relevant adenoma. I don't think there is a non-relevant adenoma. And if you look to the adenoma detection rate, if you want to go high, very high up to the level of the expert, we need to increase the detection of these small adenoma, especially for young people. It's very important that we detect as much as possible those adenomas and prevent in the long term the risk of colorectal cancer. The second goal of colonoscopy is characterize these polyps. Are they neoplastic or non-neoplastic, meaning adenomatous or hyperplastic, because it is relevant for the strategy to treat these polyp. And of course, the kind of treatment that we are going to apply depends on many factors, including size, location, and morphology. So when we look to detection, let me remind that it's very important that we consider the basic point of colonoscopy. So it's very important that the colon is very well prepared. I do insist again on the ESGE guidelines recommending split bowel prep. It's important also to sedate our patients, and whatever the kind of scope you're using or the artificial intelligence you're using, it's extremely important that you completely expose the mucosal folds, because AI doesn't see whatever you do not expose. It's important that you adopt a very, very dedicated technique in withdrawal scope from cecum to the rectum, just looking to all corners, exposing all the folds, trying to flattening all the folds, because this is crucial, instrumental to show to artificial intelligence what is to be seen, and of course pay attention to withdrawal time. So these are a couple of videos showing that if there is a very good bowel prep, you pay attention, you can detect that kind of lesion that normally are missed, especially into the right colon. This is a nice size raised adenoma with a typical appearance at the BLI, which is extremely good line modality to make a polyp characterization to look to P pattern and vascular pattern. So okay, so in terms of ADR, we keep insisting that we need to have ADI very stable. So my suggestion is to everybody to record the value of ADR. Everybody should know what is his or her own ADR, and all medical facilities, all hospitals should know what is the average ADR for the endoscopy unit. Because statistically speaking, we know from the paper in New England Journal from that correlate group that for each 1% increase of detection of adenoma, there is a potential decrease of 3% of colorectal cancer. So it's a very protective effect in terms of long-term protection from colorectal cancer. So don't forget this figure, because all the time you're going to increase 1%, you're saving a lot of lives. So of course, the main problem that we have with the colonoscopy right now is the huge adenoma detection rate variability. So if you look to the papers, this variability is extremely significant. There are so many papers reporting this variability, and of course, if I have to choose a guy for having my whole colonoscopy, I would prefer to have the top detector rather than a very bad detector. And this is a very nice paper that I want to report from clinical gastroenterology. They just looked at to private practice. So this is the standard situation of colonoscopy in the Western countries. So, and they reported such huge variability. So there were physicians having a 13% adenoma detection rate rather than some other top detectors having 41%. I do believe this variability is really unacceptable. So we cannot risk to have in this space so many missed polyps that can lead to increased risk of interval cancer. So this is a very recent paper this month in the Red Journal, American Journal of Gastroenterology. And these are data that has been extracted by the QUICK program. You know that in the US there is this QUICK program where all medical facilities, they do report the outcome of colonoscopy with the ADR. And they carefully looked at the data and they reported that if they should give a new value, a new threshold for ADR, that adjusted to US population where colonoscopy is a primary tool for screening, they don't do FIT. So the ADR should be as high as 40%. So the bar is going to be extremely high, and we need to work constantly to increase our ADR and to keep it very high over the time. So I mean, there should not be variability of ADR for the single operator between morning and afternoon, or from one day to the other day. So how we can do this? First is the human factor. We need to be very committed. We need to do training. We need quality control, because quality control is a very nice way to put under pressure ourselves, making sure that we know that we are going to be controlled and that we need to get the ADR very high. But the other part is technology, because technology means that we get advantage from any improvement technology is presented by the companies. And of course, one of the technology we are discussing today is the G-Eye. And I'm so glad that Roger already presented that beautiful video showing how easy it is to use, but also how useful it is, especially in flattening the polyp. If I may add another point, that I love this scope when I am doing a very difficult therapeutic procedure and I am in an area where I feel unstable, especially around the flexures. So when I have to remove a big polyp in the right flexure or the left flexure, and my scope keep going back and forth, I do prefer to switch to this scope, because just once you have inflated the balloon, it remains very stable and it allows you to precisely target the polyp and make resection much safer. So what is the G-Eye scope has been said already. So this is a durable balloon. You can inflate and deflate with the pedal control and allow the physician to do a lot of stuff, including flattening the polyps, flattening the mucosal folds, and exposing better the polyps for detection, but also for removal. The other technology we are going to present today, and also I have to say thank you to Silvia for the way she presented the data about AI, is the artificial intelligence. So FUJIFILM has been the first company being approved at the same time for detection and characterization, which means that in the same system you have real-time support for detection. So artificial intelligence telling you where you are missing the polyp, so you will focus your attention in the part that is reported by the artificial intelligence, but also a real-time characterization. It's been shown by Roger. It takes just 1 to 2 seconds and you get an answer. Of course, you're still the boss of the colonoscopy, still the boss of the procedures. So the procedure is not totally controlled by AI, but just supported by AI, either for detection or for characterization. It's still the final decision remains in the hand of the physicians. So briefly, the first paper reporting the application of AI in colonoscopy comes from a Spanish group. They published it about 5 years ago in Endoscopy, and this paper showing the potentiality. There was a sort of in vitro study looking into videos, and they reported the outcome. And when we are 5 years later, so this paper has been already mentioned by Silvia, and this paper that comes from our group, from Marco Spadaccini, who is a very talented young endoscopist working in Milan with us. So what we did, we compared all the different modalities that have been applied to increase adenoma detection rate, and we compared all of them versus artificial intelligence. So the conclusion of this network meta-analysis, where we have compared the virtual chromoendoscopy, traditional chromoendoscopy, fuse, endocarp, water resistant, whatever has been reported to increase ADR, the truth is, guys, that artificial intelligence is superior to all other methods in terms of increased adenoma detection rate, adenoma miss rate, and advanced adenoma detection rate. So this gives us a lot of strength to apply as much as possible, as soon as possible, AI in all in our all endoscopy unit to increase the capability of detection of polyps. So this is a video you have already seen how does it work, reporting the fact that sometimes you have a small flat lesion that you may miss. I'm very concerned to miss this lesion, especially in the right colon, because when you miss these lesions in the right colon, we know we can increase the risk of interval cancer. So when I present about AI, there is always somebody asking, okay, but this is going to be noisy, so it's a problem because there is a lot of false activation. I don't think it is going to be a relevant issue. This is a video of a patient that I scoped today. I can show you there were some seeds into the colon. They are leading to very short activation, but overall it's not noisy. It's not impacting the quality of my examination. It's not disturbing at all what I'm doing, but rather it's helping me because it's telling me where there are areas of attention that I need to look very carefully. So activation of the eye by no relevant future is not a problem, and we did a study on that. The study is going to be submitted, and we compared in 40 colonoscopy videos. We compared the performance of two different AI systems, the G-Eye and the CadEye, and we looked specifically to the false positive. We looked at the number of activations, so number of false positive colonoscopy, the time for false positive, the impact of total withdrawal time, and the overall diagnostic capability in terms of detecting polyps. As you can see, everything was extremely equivalent. So we can tell you whatever you're going to use, the risk of being, I would say, affected by false positive issue is almost nil, zero. So at the end, a few words about polyp resection. What is really new in this field? Of course, now everybody's going to ESD, but I would say that probably we need to tone down this and look to other possibility for polyp resection. One is cold snaring, the other one is underwater EMR. And finally, I want to reinforce the concept of hybrid ESD, which is just cutting all the mucosa around a little bit of submucosa with the ESD approach, and afterwards snaring off to facilitate the resection in one piece, shortening the time and also reducing the risk of complication. So let me show a couple of short videos. This is a typical situation, typical indication for all the EMR. This is a nice SSA into the right colon. You can apply your B-line modality, so you can easily characterize this for sure, and SSA in the right colon. Once you have done this, you have spent a little bit of time. I do suggest before you do cold EMR for lesion larger than 1 centimeter, especially if they are flat, to inject. Why injector? Injecting a little bit of blue dye is allowing you to see much better the borders of the lesion. It's important that you remove taking a little piece of normal mucosa, so you do not risk to leave pathologic tissue in nearby the scar, and it takes very little. And this is a submucosal fibrotic pedicule, and normally if the lesion is about 10 to 15 millimeters, you use a cold snare, dedicated cold snare. Don't do this with the traditional snare. So just 2 pieces and everything is done. You can use the water, inject the water pump to again increase the visibility of the borders, and it's up to you. We here applied clips because the patient was taking anticoagulants. So let me show another situation. This was a very unstable patient, so unstable position of the scope. So I used a DJI scope, I inflated the balloon. This was also, I think, 2 days ago, yesterday. And I used this combination of this inflated balloon and dedicated snare for cold resection. You see, this snare allows you to go very quickly to the target and remove the lesion. And normally I apply this technique for all small and flat polyps into the right colon. And using the dedicated snare, it's very quick technique, very, very fast technique. For sake of time, I will go faster and I will show another procedure. So this is typical situation. A patient has been scoped 3 years before, and there was no diagnosis of polyps. So his patient was sent home, and he was saying everything is fine. You need to come back in 10 years. So 2 years later, he did FIT because he was not doing well somehow, but there was no specific symptom. At that point, we repeated colonoscopy because FIT was positive. What we found, look to this. This is a typical serrated sessile appearance into the right colon. When you use BLI and LCI and underwater, you can nicely see this is the structured pit pattern. This is pit pattern 5. So this is a lesion that must be removed in the single piece. So how you can do this? There was a lot of fibrosis. So I used the combination of hybrid and underwater. I love the combination of a hybrid underwater because it allows you to go en bloc also for lesions as big as this one. And again, when I remove such big lesions en bloc, especially in the right colon to avoid delayed bleeding, I remain underwater and apply the clips to completely close the resected site. So this was my last slide. I'm so grateful to have been talking with all of you. I'm also very open to answer to all of your questions. Thank you so much for your attention.
Many thanks, Alessandro, for this brilliant talk with useful tips and tricks for our daily business. Is there already any data available showing that G-Eye has a positive influence on our ADR? And if not, what is your experience with the system? Do you detect more lesions than using a normal endoscope?
That's a good point. So we are using more and more. It's a matter of technique. If you're using properly, you're flattening all folds, especially in the areas where the colon is very big. It's difficult for you to flatten the scope with a tip of scope. So it's going to show us a lot of tiny and flat lesions that you normally miss. So in combination with retroflexion into the right colon, I do suggest that using this kind of technology is significantly improving your ADR and keeping also contributing to keep it very high.
Okay. Thank you, Alessandro. I think there are plenty of questions from the audience, and I would like to start now our discussion round. Maybe we can start with some short questions to Silvia. Please also some short answers. So do you think, Silvia, CadEye does increase detection of sessile serrated lesions? Does it decrease the minimal withdrawal time of 6 minutes? And does it produce more false positive signals in patients with inadequate bowel prep?
Well, about SSLs, I have no answer yet because we did not analyze this issue in our data because we still have enrolled little more than a half of the patient, but sure we will analyze this issue. I don't think that the use of artificial intelligence could challenge the minimum withdrawal time of 6 minutes. And moreover, not just the time of withdrawal, but also the quality of withdrawal exploration, which is a mainstay for lesion detection. So I don't think that we have evidence on AI which can challenge the timing of the 6 minutes for withdrawal. And CadEye, as Professor Repici said, can be misled by residues or seeds in the colon, but also studies in the literature have evaluated that the additional time to control these items and to judge them as false positive is up in terms of seconds per procedure. So an expert endoscopist who gets acquainted with artificial intelligence can easily judge that that blink or that beep the machine does is a seed or is a diverticulum or another item which can be seen as a discrepancy in the mucosa, which is the system on which AI detects lesions in the colon. But I think that the issue of quality preparation has always to be targeted and has always to be improved, not just for artificial intelligence, but generally speaking for colonoscopy.
If you may, so this is very anecdotal and based on the fact that we use on a regular basis AI, and I think Roger can confirm this. So I do believe that the AI is going to increase also detection of serrated lesions in the right colon. They are all picked up by the AI. So every time I'm distracted, I see this superimposed box, and I also have audio signaling there is something wrong, and look to the point carefully. I have seen so many serrated lesions. Of course, it is going to be reported in a study. We do not have any final evidence, as Silvia said, but the feeling in general is, I think, is in that direction. I don't know, Roger, if you want to comment on this as well.
I think the major advantage of the artificial intelligence is you have like two doctors checking the colon.
And the other one is better than us. We have to recognize.
You.
I think
honestly speaking,
when you observe yourself during a colonoscopy, your eyes switching around the monitor, looking here and there and this, and it's the same when you have the CadEye on, then the boxes hit here and there, and you will check it and double check it, and then there's a seed or a diverticular, and then you move on. And so at the end, you're a bit more alert as an endoscopist, because there is always another one beside you that tells you maybe there is something and maybe you have to remove it. And I think that's the big advantage.
Using AI systems, do you think we are ready for the diagnose and leave or the resect and discard approach, at least for smaller polyps?
No, I don't think so. The problem is the actual system shows you only neoplastic and hyperplastic. And hyperplastic could also be serrated adenomas. And when you have a hyperplastic polyp on the right side, you always have to remove it. When you have a hyperplastic alert on the rectum, then you can discuss it to leave it, of course. But I think the technique is not that good to make this decision. So the pathologists, they still have work to do.
Silvia, what is your opinion about this?
Well, we had some studies on the resect and discard strategies. And, yeah, I think that is a kind of cultural problem of us as endoscopists, because we are used to have faith in what the pathologist says, but also our eyes are able to identify a small, tiny, diminutive polyp in the rectum as an hyperplastic lesion, and maybe we leave it in. So personally, I don't resect all diminutive lesions in the rectal sigmoid. I think that if artificial intelligence is able to reach the benchmarks for an optical diagnosis, at least, for example, for rectal sigmoid hyperplastic lesions, it could give us more strength and more confidence, for example, to print the image with the green box, the green shadow in the small box you showed us, Roger, and just a proof that an evidence that that lesion was judged by the endoscopist as hyperplastic, but also by a machine with performances which can be stated and put on the trademark with those characteristics. So maybe it could give us more confidence in applying the resect and discard strategy. Of course, scientific societies will have to endorse this practice, either by the endoscopists using chrome endoscopy or by artificial intelligence as an adjunct.
Can I make a very short statement? I think in a couple of years, very soon, probably 1 or 2 years, everybody has to trust to AI evaluation and get a resected scar strategy because it's a lot of cost.
I agree, and the better the
say
systems will get in the next few years, the more we will work with these strategies. I completely agree. There are some questions about the role of CadEye and IBD. Alessandro, do you have any experience?
No, CadEye has not been tested in IBD patients. There are a couple of algorithms that have been developed based on IBD videos from different startups, and there are a few publications coming in endoscopy, gastrointestinal endoscopy. I think the future of AI in IBD is very important. They will allow us to have a sort of automatic scoring system of the stage of the disease that would be very similar to histology. So since it's the target of biologic therapy is just to reduce inflammation to almost zero, we will have artificial intelligence telling us that the level of inflammation is 0, 1, or 2, or 3. So this will allow us much more, I would say, reliable evaluation, because when you look to the evaluation from physician to physician, there is a huge disagreement. Okay, so using AI will allow us to be very consistent across different physicians and different patients.
There are also 2 questions about reprocessing and disinfection of the G-Eye system due to the
very simple, like all other scopes. Doesn't take any specific care. No, Roger, you agree with that?
Yeah, absolutely. And I think one you have to know is the balloon is fixed on the endoscope. You cannot remove it yourself. So you wash it.
Durability is as long as the scope works, the balloon works.
Exactly. Yes.
I think it's important to know for the participants that the balloon is fixed, mounted on the scope, and it comes
It's
with
part of the scope.
Yeah.
It's part of the scope.
Exactly. Okay, so unfortunately we are running out of time. So I think that's why we have to finish our discussion. Thanks a lot to all the panelists for the interesting debate and you for your questions and your interactive participations. Let's finish with some closing remarks. So if not already done, please save the date for next year's hybrid ESG days in Prague at the end of April. And be aware about some new benefits for ESG members, like the My ESG Tutor, a module-based e-learning system, or the Quality Check app, which helps you to measure the quality in your endoscopy unit. Don't miss next week's ESG webinar, Going Fishing, Tips and Tricks for Endoscopy in Foreign Body Ingestion. And now we are at the end of our satellite symposium. I suppose you learned a lot from our excellent speakers about the advantages which come along with the latest technologies, G-Eye and CadEye. Many thanks to our speakers, Silvia, Roger, and Alessandro, as well as to FUJIFILM and ESG for organizing this webinar. Special thanks also to Gabby and David for the appreciated technical support. Have a nice evening, maybe with Swiss cheese and Italian pasta. Take care, stay healthy, and goodbye. See you.
Bye-bye. Thank you.